vai lì.
No, la presentazione può essere fatta da qua.
Esatto, è lui che va lì.
È chi fa lo speech che va lì.
Quindi noi siamo qui al limite, se vuoi ci alziamo in piedi oppure...
Di solito ieri la presentazione veniva da qua, ok? Senza nessun problema perché compaiono le immagini, no? E sono enfatizzate. Però se tu vuoi andare lì, problema zero. Ma se tu preferisci andare lì, problema zero.
Va bene, andiamo tutti e due, lì tanto ci sono tutti e due, però poi ci mettiamo tutti e due.
So, good morning to everybody and welcome to the second day of this meeting on the artificial intelligence in healthcare. It was a surprise to see yesterday and also today so many young people here, and once again I think that the young people represent for sure the future, and since there is so important attention for this topic, this means that you will be the owner of this topic in the future, and the people who will apply this technique in the everyday job, I think, but in particular in the healthcare. My duty is just to introduce the chairman of the first session, who are Professor Eugenio Baraldi, Professor of Pediatrics at the Department of Women and Children Health at the University of Padua, and Professor Fabrizio Dughiero, Professor in Electrical Engineering at the Department of Industrial Engineering at the University of Padua. Please. Okay.
Well, welcome to everybody. Also on behalf of Professor Dughiero, we welcome you to the second day of this excellent meeting. Let me say that it is great to see so many young people, so thanks to be here. Let me to congratulate with the organizer for the excellence of this meeting and the huge success. I'm a clinician, I'm a neonatologist, and what I understood yesterday is that until now, artificial intelligence will not replace a clinician, but will empower the work of clinicians. And so, please, Professor Dughiero, can you introduce our special guest?
Yes, with pleasure. So good morning, ladies and gentlemen. Some words about our keynote speaker. Professor Doria is a senior investigator in the section of genetics and epidemiology, as well as co-director of the molecular phenotyping and genotyping core of the Joslin Diabetes Center. He's also professor of medicine at Harvard Medical School and a professor in the Department of Epidemiology at the Harvard T.H. Chan School of Public Health. Professor Doria received his medical degree and his doctorate in endocrinology and metabolism from our University of Padua in Italy, after which he completed a research fellowship at the Joslin Diabetes Center. Prior to coming back to the Joslin as a faculty member, he was a senior lecturer and honorary consultant in endocrinology and diabetes at the Guy's Hospital and the University of London in Great Britain. So, the title of the keynote speech of today by Professor Alessandro Doria is Leveraging Genetics for AI-based personalized medicine of common multifactorial disorders. Please, Professor Doria, you have 30 minutes and then 5 minutes for question and answer. Thank you very much.
Thank you. Good morning. It's really a great pleasure to be here, and I'd like to thank the organizer for the kind invitation. I'm a graduate of this university, and so I really treasure every single opportunity I have to come back to my alma mater. And today I'm going to tell you about how we can leverage genetics for AI-based personalized medicine of common multifactorial disorders. And I will do so by telling you about cardiometabolic disorders as an example of multifactorial disorders where we can apply genetics for this kind of personalized medicine. How can I move the slides? Here we go. So for those of you who are not in this field, cardiometabolic disorders are a group of heterogeneous diseases which are intercorrelated, meaning that they often occur together in different type of combinations. And they are all characterized by alteration of the glucose and lipid metabolism, usually related to insulin resistance, a decreased insulin sensitivity. And another important characteristics, and which is actually why they are called cardiometabolic disorders, is that they are associated with an increased risk of cardiovascular disease and especially coronary artery disease due to an increased prevalence of atherosclerosis. Including in this group, we have usual suspects, dyslipidemia, diabetes, obesity, insulin resistance, hypertension, non-alcoholic fatty liver, chronic kidney disease, and also gout. And they are really prevalent, and they are a major public health problem, as indicated by, this I think is the wrong presentation. Anyway, interesting, but I had changed the presentation this morning, and apparently this has not happened. But anyway, let's continue, and hopefully everything will be fine. And so I was saying that they are really an important public health problem because they are common, and as indicated by the fact that the cardiovascular disease is the most common cause of death in the Western society. As it is true for other multifactorial disorders, they are due to an interaction between the environment and the genetic background. And we have known that the genetic factors are important since the 80s, about 40, 50 years ago, when there were the first studies of families indicating that there was a familial aggregation of these disorders. But it is only in the past 10 or 15 years that we have really started to understand what are the genes that are involved. And this progress has been due to two major factors. One has been the development of new assays based on chips through which we can interrogate the entire genome for association with a disease. And of course, this has been possible because also we have a genome-wide characterization of genetic variability due to the Human Genome Project. So it has been possible, as I was saying, to do genome-wide association studies where millions of variants are interrogated along the chromosomes, along the genomes, for association with a disease. And this approach has been spectacular. The success has been spectacular, especially for cardiometabolic traits. As of 2023, last year we had over 1,000 independent losses for BMI and obesity, over 100 for type 1 diabetes, over 500 for type 2 diabetes, over 1,000 for blood pressure and hypertension, over 300 for plasma lipids, and over 200 for cardiovascular disease that are not already included in those for the traits predisposing to cardiovascular disease. And these genes are acting in a complex way, in the sense that there are different genes in different persons. Also, one person can host many different genes that predispose to these disorders. And the two aspects are usually combined so that basically each person has his or her own pattern of genetic variants shaping the susceptibility to these cardiometabolic disorders. So the question then becomes, what do we do with all these genes? And one application that we can gain new insights into the molecular pathway underlying this disorder so that we can find new targets for new intervention. And the second application is that we can maximize the effectiveness of preventive intervention and therapies. And today I'm going to focus on this second aspect. The first aspect is really important, but of course there is no time to do everything today. So when we talk about maximizing the effectiveness of preventive intervention, we're talking about maximizing this ratio between the benefits and the adverse effects. So we want to maximize the benefits deriving from this intervention, and we want to minimize the adverse effects. When we develop a drug, and when we push that drug through the regulatory path, we look at the average ratio, benefits to risk ratio in the population. However, this ratio varies in the population. On one extreme, we have people who derive no benefits and they have a significant adverse effects. On the other, on the right, we have individuals who have major benefits without any significant effects. When we interact with the patient, we don't have to look at the average. We want to look at the individual ratio in that person for that intervention. And we want to be able to select people who are on the right of the distribution. People will derive benefits, and they're very unlikely to have significant adverse effects. So the idea then is to use the genetic profile, basically the information that we get, all those genes that I've shown you in the previous slides, and put them together with medical history, lifestyle and diet, information on laboratory data, comorbidities, other therapies, environmental exposures, and all together use them as input for algorithms of AI-based or machine learning, more specifically, so that we can estimate what is the the benefit to risk ratio for each intervention that we can apply to a person, and then choose what are those interventions, what are the best ones for that person. Today, I'm not going to tell you how to do this integration. It's, I don't work on AI specifically, and in this room there are so many experts that could do this job much better than me. What I'm going to do is to tell you what kind of information the genetic profile can provide in this context. So let's start from how we quantify benefits. The benefits can be quantified by absolute risk reduction. Basically, it's the product of the risk of a person times the relative risk reduction. So just to explain you, I put some numbers here so that especially the young people in the audience can follow. So we have, for instance, a 6% risk reduction resulting from a 20% risk with a 30% reduction. And the same can be derived by having a 30% risk, a 20% reduction. And then when we have, both the 30% would be 9%. So very easy math, nothing special. So with genetics, we can identify people at high risk of disease, so we can increase this absolute risk reduction in that way. But also other variants, sometimes even the same variants, but other variants can be used to instead increase the relative risk reduction so that we can identify patients more responsive to treatments. So let's start with the variants that increase the risk. And this is an example about coronary artery disease. And just to orient you, you have on the x-axis, so each dot is a variant. And on the x-axis, we have the position on the chromosome. And on the y-axis, we have the odds ratio, which is a measure of the magnitude of the effect of these variants on predisposition, on risk of disease. What you can see in this slide is that with a very few exceptions, there is a fairly small increase in risk associated with each variant. Many variants are below 10%, and other variants are below, between 10 and 20%. So individually, these variants are not going to tell us much about the risk, but they can be very informative in aggregate. And one way to consider them in aggregate is to build a polygenic risk score. And the easiest way is just to sum the number of risk allele at each locus in this score. This number varies from 0 to 2, so that if a person has no risk allele at any locus, then you have a risk score of 0. If they have 2 risk alleles at each locus, the score will be equal to the number of variants in the score times 2. There are more complex way of doing this by weighing each variant for the magnitude of the effect, basically by multiplying each score for each locus by the measure like the odds ratio. But the basic scheme is that basically we are putting together all the variants as a score. And this is an example using those genes for cardiovascular disease that I showed you in the previous slide. This is an analysis that we did of the ACCORD clinical trial, a clinical trial that included 10,000 people with type 2 diabetes. And you can see how people with the genetic risk score in the upper tertile has a 75% increase in risk as compared to people at baseline. This was an analysis done in collaboration with Mario Luca Morieri, who you saw yesterday presenting on this podium. And when we added this score to the clinical model, we saw that the significant risk reclassification, and there was a significant improvement in as an index that we use, which is the integrated discrimination improvement, went up 8%. And usually we take 6% as the threshold through which when a biomarker deserves to be included in a predictive model. So this score seems to perform in a way that is conducive to improve the identification of people at risk. Now, this is a score that was based only on variants found to be significant in a genome-wide association study, but this can be extended to the entire genome. So you can include millions of variants, and you weigh each variant for the effect. So variants which are not associated will not be included basically in the score because their weight will be 0, and those which are very highly associated will be instead have a higher score. And an example of this is a score that was published a few years ago for obesity, and basically was about 2 million variants in 120,000 people from the gene bank. And you can see how people in the upper decile had a 15% increase risk over 25 years to become obese, as opposed to only 1% in the people in the bottom decile. And on the right, you can see the impact of a hypothetical intervention decreasing the risk by 25%, 0.75 relative risk. And you can see that in this way you have almost 4% reduction in the top decile as opposed to a 0.3% in the bottom decile. And when you translate this in a number needed to treat, you need to treat only 26 people in the upper decile to prevent one event, as opposed to treating 300 people in the bottom decile to prevent one event. So if you have an intervention that is costly or is difficult to obtain or has a lot of adverse effects, of course you will treat people who are in the upper distribution of this score, and instead you will refrain from treating people in the bottom. And another added advantage is that genetic factors are present at birth. While the clinical predictors improve in their capacity of predicting an event as they get closer to the event, genetic factors can predict at birth, so that it is possible to identify people at risk for disease in their 50s or 60s, in the adolescence or even childhood. And then we have a time horizon of the entire life to be able to implement preventive intervention. There are also variants that, in addition to increasing risk, also they increase the relative risk reduction. And one example is for a class of drug called PCSK9 inhibitors, which are drugs for coronary artery disease. And you can see that there were two studies showing that people who have a genetic risk score for coronary artery disease in the upper part of the distribution, they had also an increased relative risk reduction in response to these drugs. These drugs are fairly expensive, so you can see how this can be useful to rationalize the implementation, the use of this drug in the population. Another example is concern fenofibrate, which is a drug that has been used for decades to decrease triglycerides and increase HDL. And in the ACCORD study, one part of the ACCORD study, they tested fenofibrate versus placebo, and they found that this drug was effective only in people who had increased lipid levels, increased triglycerides. So they had basically a combined hyperlipidemia. So we wanted to see, again, together with Mario Luca, whether we could identify variants that would tell us what are the people, whether there are people with normal lipemia who could actually be also responding to this intervention. And what we did was to look specifically at the locus for PPR alpha, which is the target of fenofibrate, and we found that there was indeed a SNP interacting with the fenofibrate for the risk of CVD events. And the interaction goes this way, that among people without dyslipidemia, people carrying one genotype, TT, basically experience the same reduction in cardiovascular event as people in the dyslipidemia group. While instead people with the TC and CC genotype had no effect whatsoever. This is on the upper part of the panel. Unfortunately, the pointer doesn't really work with this very bright screen. So we can envision a new way of a new paradigm. The current paradigm is that we treat only the people who have dyslipidemia on the left. But then, instead, the new paradigm would be that instead people who have no dyslipidemia are tested, and we treat the people with the TT genotype. In this way, we double the number of people that can be treated with this drug. And note that the number needed to treat is similar in the people who have TT and normal lipemia compared to the people who instead have dyslipidemia. So this is a significant application of these genetic findings to clinical practice. Now let's talk a bit about adverse effects. And I'm going to, as an example, to talk about intensive glycemic control, which means bringing glucose to near normal levels in people with diabetes. And there was a study, again, ACCORD, in which they tested whether this intervention could prevent coronary artery disease events. And what was found that indeed there was a 20% reduction in non-fatal myocardial infarction. However, this came at the expense of an increased cardiovascular mortality. So this was puzzling, and the reason for this paradox are not clear even now. But our question was, can we identify people who can derive benefit on non-fatal myocardial infarction without experiencing the increase in cardiovascular mortality? We did a GWAS in the intensive arm of ACCORD for cardiovascular mortality as outcome, and we found two SNPs, one on chromosome 5, SNP meaning single nucleotide polymorphism, one on 5 and one on 10, that were significantly associated. They exceeded the stringent threshold for significant for genome-wide association studies. And you can put this together as a genetic risk score. By now you know what we mean by a genetic risk score. And the 20% with the GRS equals 0, meaning that they don't have risk alleles, there was actually a benefit on cardiovascular mortality. It was a neutral effect of intensive glycemic control in the 50% with the GRS equal 1, and in people with the GRS equal 2 or more, had threefold increase in cardiovascular mortality. So all the cardiovascular mortality excess of intensive glycemic control was in that group, in the group with a high GRS. And interestingly enough, there was also an effect on non-fatal myocardial infarction, so that people with the GRS equals 0 had a benefit also non-fatal myocardial infarction, while, and also GRS equal 1, even though it was a bit less, instead it was neutral for people with the GRS of 2 or more. So it is clear that if I wanted to apply this intervention, I would do so in people who have a GRS of 0. Probably I would do so also in people who have a GRS of 1. Certainly, I would not do this in people who have a high GRS, because it would have a major adverse effects without any benefit. And this actually can be quantified, but perhaps we can skip this because I'm running a bit out of time. But the other interesting thing is that we found doing some biomarker studies that people in the intensive glycemic control who had the protective, the good genotype at one of the two loci, the one on chromosome 5, had an increase in GLP-1 during treatment in the intensive glycemic arm. GLP-1 is a hormone with many different effects, but one is cardioprotection. By contrast, people with the TT genotype at a 57.922 locus had a decrease in this cardioprotective factor. Now, nowadays we have drugs which are called GLP-1 agonists, which mimic the effect of GLP-1, which were not available when the Accord clinical trial was done. So rather than not treating with intensive glycemic control people with a bad genotype, we can target them with GLP-1 agonists, because it seems that their problem with the responding in that way to intensive glycemic control is due to a lack of GLP-1. So going back, I hope that I have really give you some example of what genetic can provide in terms of information for this algorithm of, to try to personalize medicine and integrate this with the information from other part of the clinical practice through AI. And there are many more examples for other disorders, and other genetic effects can be found actually through this integration. The analysis that I showed you are relatively simple because we had a relatively small data set. 10,000 is small. Accord at 10,000 people, but 10,000 is small if you want to have all this analysis of interactions. So there will be more to come if we are able to implement this kind of system. And so I hope that in a not so distant future, when a patient comes, as part of the basic workup, there is also a sample that is being drawn to do a genome-wide analysis. Can be with a genome-wide array, or now can be with a whole genome sequencing. And perhaps that same sample can be used for transcriptomics, for proteomics, or metabolomics. And so we can have a full leveraging of all the omics technologies that are available at this point. I still have a couple of minutes, 1.5 minutes to be precise. And I think that I want to discuss with you very briefly, and perhaps we continue during the discussion, what are the challenges moving forward. One is, what data set do we use to develop and validate genetic-based personalized medicine algorithms? Clinical trials are usually small. The data set that we have been using are also not complete with all the information that we need. Biobanks have large sample sizes, but the phenotype information usually is not that great. So I think that we have to design studies, and we have to go to the medical records and use those data. But of course, we have also to get the samples of blood, what I was saying in the previous slide, so that we can couple the data in the medical records with the data from genetics. The other issue is at what point we think that this algorithm can be ready for implementation. We were in the genetic field, the mantra has been replication, replication, and replication. However, I think that given that the resources that are necessary for this, we'll have to be a bit more modest and try to implement this when we think that is a reasonable algorithm, and then try to see just in practice how this works with the continuous feedback and refinement of the algorithm. Of course, we'll have to be careful in how we introduce this in clinical practice. We want to have the collaboration of professional societies and perhaps very nice and smart software so that we entice physicians in using them. And of course, this has been overarching theme in the entire presentation, in the entire meeting. What is the role of physicians? And again, it's about empowering physicians, it's not about substituting physician, and I will not discuss, we can discuss this after the presentation. So in fact, at the end, I would like to thank all the fellows who have been working on this, especially Mario Luca and Hetal Shah about the data in Accord, all the collaborators, and thank you for your attention. Happy to take any question.
Thank you, Professor Doria. So, any question? No questions?
Thank you, Professor Doria, for this comprehensive, inspiring lecture. No doubts that genetic profiles can identify people at risk of chronic non-communicable diseases and so on, as you have mentioned, but environment is central. So environment means lifestyles, means interventional, preventive interventions. So what is the next step we have to arrive to preventive chronic non-communicable diseases?
I think that really we need more data, as I was saying, and I think that we have to go to real world and try to integrate the data from medical records. We're doing pharmacoepidemiology and getting samples from every patient that goes to the hospital, every patient who comes for a clinical visit. We get a sample, we get the DNA, we do the profiling. And then, we can see, how this is working, because of course this is our hope, but we don't know in practice how this will be. We have data from very special data set, right? Like Accord was a clinical trial with very clear inclusion criteria and strict inclusion criteria. We want to see how this works in the real world. Then, the next step, which I didn't touch on this, is that we need to enroll our colleagues who do decision analysis. And they put in this equation what are the cost financial, organizational, and then, we can devise a program so that we can maximize our resources. And given that you are a pediatrician, yes, I think that we can go to childhood, and we don't want to stigmatize anybody, right? We don't want to say, okay, you will be a fat guy when you get old. No, we don't want that. But if somebody is really at risk and we have interventions which are costly or difficult to implement, then yes, why don't we start, from children?
We need to start from children, probably, with the lifestyles.
Yes, absolutely. Now, on the type of nature of the intervention, of course, I'm not thinking about drugs in kids. I'm not thinking about giving Ozempic to all the kids. What I'm thinking about is teaching them how to eat well. And of course, this is for everybody. But there can be very intensive program. Summer camp, okay? We send the kids to summer camp where they learn how to eat, how to exercise. Perhaps we cannot send all the kids to summer camp. We send those which are at high risk.
So
Thank you. Any more questions? No, so
I have a short question. So the majority of people attending this conference are young people at the beginning of their careers. Do you have any recommendations for them for becoming good researchers, good doctors for the medicine of the future? Do they need much more knowledge on physics, mathematics, engineering? What is your opinion?
Okay, well, when I went to the States, I had a very rudimental knowledge of statistics. And then in 2004, I went back to school and I got a Master of Public Health. It was a revealing experience for me because what I had learned by osmosis, just from my mentors, finally I could see that structured. So I think that statistics, but not statistics, what is a t-test. Statistics, epidemiology, how you design a study, how you analyze the data, what is a model, logistic regression, Cox regression, these kind of things I think are missing, or at least they were missing when I was a student here. I don't know whether now they have these opportunities, but I think that certainly epidemiology and biostatistics are really, really key for them, not only to be investigators in the future, but to understand the evidence, so that when they read a paper, right, they can understand what is the evidence. Can I trust this evidence? Yes, it is a P of 0.05. Is it something clinically significant? So I think that all this should be part of the curriculum.
Thank you very much. So I think that now we can close this session. Thank you very much again, Professor.
Thank you so much. Thank you.
So, good morning. We are ready to start now session number 4. And the topic of the session is explainable, actionable, and responsible AI. So really looking forward to exciting presentations and discussions. So I'm pleased to invite the first speaker of the session, who is Professor Carlo Combi, Professor of Computer Science at the Department of Computer Science of the University of Verona. And the title of his talk is Explainable AI in Medicine Towards a Foundational Definition. The floor is yours, Carlo.
Thank you to everyone to attend this presentation. I hope to be able to continue the starting presentation of Professor Doria. I didn't talk with him, but it's exactly a continuum with respect to what I will present to you. So that's the outline of the presentation. I will start with some basic consideration about AI in medicine and what is explainability, especially applied to medicine. And then I will propose a foundational definition of XAI in medicine with some question and proposition. And the main content of this presentation has been published in a paper with the colleagues. Some of them will be here today, published on the AI in Medicine journal. So let me start with something that is already in the previous presentation. So mainly when we deal with AI in medicine, we observed in the last, I would say, 30 or 20 years, we assisted to a drastic shift from some, even in the research and in the application context, from some knowledge-intensive application dealing with the representation of medical knowledge, how to reason on this kind of knowledge, how to represent this knowledge, to data-intensive applications. So we have a lot of data, some of them were in the previous slides, coming from different sources, and we have to mix and to integrate and to support with our software system some really important information during decision-based tasks. So the idea is that the AI in medicine and the XAI I will discuss today is mainly related to some decision clinical task. So a quite wide definition of AI in medicine in this direction is like the one on the slide, is the science dealing with studies, project application, research related to support decision-based medical tasks. The support is related to the fact that we will not in any way replace the physician, obviously, through either knowledge or data-intensive computer-based application. And the improvement and the extra gain with respect to the application of this kind of software tools is that this kind of performances are not possible for a human care provider at the right time. The time at which we obtain this kind of information is really important in the clinical process. So let me move to the explainability with some basic definition I took from Wikipedia. What is explainable AI in general, not yet applied to medicine? XAI refers to methods and techniques in the application of AI technology such that the result of the solution can be understood by humans. Very wide. It is not said how to provide this kind of comprehension of the final conclusion of an AI tool. And the motivation for XAI are many, quite general, and we will see specifically for medicine afterwards, are related to the interpretation or the understanding of the right result, or related to error discovery and management of this kind of errors in the AI tools, avoid bias in many different ways. It could be that you find or you discover biases in the data that influence your final conclusion. You have to trust in this system, and you want to improve the effectiveness of this system. So mainly, if we apply this kind of context in medicine, there are many concerns and questions related to XAI. If we think about some either research-oriented or clinical application, there are many questions like, what is doing the algorithm, the AI tool I'm using? Does this system work as well as an expert, or it is following different lines and different paths towards a final solution? Or the system is doing what the user will do in the same situation? Or why cannot the system tell a user how it arrived at a conclusion? That's the main problem of many machine learning-based tools. They can provide some interesting solution. They cannot always provide you why they reached this kind of solution. And when we move to the tool supporting this kind of explainability, we may consider mainly two different approaches. One is named ante hoc approach. That means that the methods you use for supporting this decision-based task is explainable. We will be back on this kind of explainability. It is in general explainable because in any case it depends who is the final destination of the explanation. If I have to explain something to medical students, I will use some kind of terminology and concept. If I have to explain the same stuff to computer science students for the same problem, it is quite often that I will use a different terminology, different times, different kinds of interaction. So, but even considering these issues, there are some approaches that are explainable in the sense that they use some algorithms that can be followed that can be explained in their application, like decision tree, rule-based systems, linear approximation from a mathematical point of view, and so on. Then there are other approaches, named after post-hoc approaches, that try to provide some explanation of results reached by black box machine learning or deep learning or whatever learning you are imagining, models that cannot be simply explained by adding some other tools, some other software layer. And these machine learning models can be deep neural, random forest, support vector machine. Someone more technically oriented could say that support vector machine can be explainable. Yes, if you know a lot of mathematics, if you are trying to face simple situation, otherwise you are not able to follow what are the lines followed by this kind of tools. So mainly this XAI medicine is focusing on providing, adding some help in using machine or deep or whatever you want learning that are black boxes approach to understand why there is some final conclusion like prediction, classification, diagnosis, and so on, and discovering for the possible discovery of errors. Going again more focused on XAI medicine, we observed we derive some kind of dimension analysis. What is related to this explanation? The content of explanation. What is being explained? The stakeholder of the explanation. As I said before, the final user of this explanation may require different techniques for providing the right kind of explanation. And the goal of explanation, why is explainability required? It is required in every step of the decision support task in some medical context, or when, how long, and how frequently you provide some explanation. When you, usually in this context, I provide some example that is not really medically oriented. Every one of us is driving a car, and we are quite able to use the car in the right way, but we are not thinking to explanation of why the car is moving, what is the principle of wheeling and the engine, and why do we need the fuel and so on. We know that there are some mechanisms that allow you to provide a kind of movement or stopping the car and so on. We are more or less in the same domain. We don't require always a deep explanation. We have to use this kind of tools. Sometimes, in some moment, we require the right explanation at the right level of abstraction. And how to represent explainability. It may be that it is an explanation in natural language, but it could be an image allowing you to understand why the system provided some final conclusion. So again, I didn't talk with the chair of the previous session, but that's the main message of this presentation. AI and explainable AI will not replace clinicians and medical professionals, but XAI medicine can be used for some more sound application in the clinical final practice to support physicians. So in this context, XAI is the technical discipline providing explanation and interpretation of results from black box machine learning techniques. The idea is that this kind of explanation is according to a specific goal. The idea is to support clinical decision making. And now moving to some kind of definition of XAI according to these different requirements, with the colleagues we propose this kind of definition. The explainability is at the intersection of many different concepts. Pay attention that in literature and in natural language scientific paper, there are many possible terms. We try to clarify some of the concepts underlying this term, but again, we say that explainability may be considered as the intersection between many different contexts, or terms or concepts, interpretability, understandability, usability, and usefulness. And I will try to introduce the different aspects corresponding to the different terms and concepts. The first is interpretability and understandability. What is the difference between interpretability and understandability? Interpretability is like to observe the result of a system and being able to predict the result of the system. You understand, for sure, and it's not mandatory, you could also not know the structure of the system, of the algorithm of the system, how the system works, but you are able to understand the final result of the system. You are able to predict what is the behavior of the system, like to predict the movement of the car without knowing the engine parts. Understandability is a little bit deeper concept. You are able to understand how the system works for reaching the final result. And that's toward the confidence in the system output. It increased the confidence towards the system. The other part that is really important, it is not so underlined in the scientific literature in this moment, is related to usability and usefulness. Usability means that if you want to provide an XI system that is really important for the final clinical application, you have to think about who is the user, whether the system is able to interact in the right way with the user. That's quite common in the human-computer interaction and software engineering context to study this kind of usability aspect. But again, you have to think about different solutions if you are supporting a clinician in a very intensive care like ICU. You have to provide explanation in a very fast way. That's different from a clinician dealing with follow-up patient. You have more time. The data are collected with a different frequency and so on. And the last one is that the usefulness. At the end, according to the usability provided by the system, the final user has to find the system able to solve some practical issues, has to be useful in the real clinical practice. So following this kind of definition, we prepare some questions and proposition that is quite common in a kind of manifesto. The proposition are, for example, what are the requirements for XAI? How can we evaluate the goodness of the provided explanation? That means that we need to be able to measure, interpret, understand all these kind of concepts, usability versus usefulness and interpretability versus understandability. That's quite common in other contexts. If you think about the drugs mentioned in the previous presentation, there is a very specific path to follow for having the certification for being able to market the drug. It could be the same for this kind of software tools. You use these software tools in some observed context with some rules, and you have to pass some steps for having this kind of XAI requirement satisfied. Another question is, if an AI system output is understandable, is it automatically explainable? Not completely, because it depends on the system providing the explanation, on who is the final user, how the system is used. Other question, what is the role of domain understanding in achieving XAI in medical application? The general tools for XAI can be a good starting point, but in order to really provide an important, I would say, and true explanation, the biomedical and the clinical domain has to be understood by the system, suitably modeled, represented, queried according to the data, and so on. And what about explainability and wisdom? Explainability is a requirement. If you want to move from data to information to knowledge, for having at the end wisdom, you have to follow this kind of path and approach. Trustworthy AI system for sure need to be explainable, because otherwise the clinician is not able to use in a proper way this kind of system. And the other final question, I would say explanation has to be provided when they are needed by the clinician or the physician or the researcher at a specific point. They cannot be the cause of some slowing down of the work, but they have to support the work at the right moment. And again, it is not enough to consider the domain. You have to use some kind of analysis also on the final user that are the destination of this kind of system. So let me conclude this presentation saying that the issue, as I try to show it to you, is XAI in medicine is quite multifaceted. You can consider this kind of property from different points of view. So you need some multidisciplinary effort involving software engineering, experts, medical informaticians, for sure physicians, and all the stakeholders of this kind of medical system. And according to this observation, there are still many works to do, many research directions. The first one I'm mentioning in this slide is quite technical. There are some symbolic, the ante-hoc approach I showed before, the rules for explaining something, and there are sub-symbolic, the black box approaches, how to merge this kind of technical approaches for providing a final explanation, how to consider the different, pay attention that this kind, even in the computer science domain, these two approaches are considered by two different communities, so we need to merge this community with some more common background, even in medicine. Then the other part is how to evaluate and improve the effects of explainable component. That's really important. There are no studies with respect to this kind of final importance of the system. When you use this kind of system, are you improving your performances, or are you slowing down just the frequency or the number of tasks you are doing in a day? Again, determining when explainability is needed is still an open problem. And for solving it, we have to deal with all the stakeholders of this system. And in this direction, we have to consider the design of user-centered and user-tailored artifacts. So the final user are the main focus of many, many research efforts. Okay, I hope that you enjoyed this presentation, at least it was not boring, I hope. I would end with the sentence by Alan Turing saying that mainly what is AI and also in medicine, an AI system is a system that is able to convince a human that he is talking with a human. So in this context, explainability is really one of the main issues to solve. Thank you.
Thank you for the presentation. There is a question from the audience. Okay, there can be a microphone for.
Thanks. Great talk, Moiri from Padova. I would like to connect to one of your last points in the conclusion, understanding when explainability is needed. I would say every time, but so the question is, when is not needed, in your opinion?
Okay, so I was thinking, let me again consider the example of the car. When you need to understand, you have then to generalize, when you are driving the car, when you need to some explanation about the car or the engine or the wheels and so on, when you have a problem, or when you want to observe some performances. When you are driving, usually, understanding how the engine is working is not your main focus. I would say similar approaches could be useful in medicine. If you are very, very fast in some software tools and they have to provide some initial diagnosis or initial problem specification, possible path to follow, not always you need some explanation. But the important point is that when you need it, you can obtain it. That's the idea behind this kind of observation.
Can I follow up? Can I follow up?
Go.
From a user point of view, I totally agree, but from a physician and scientist point of view, if we talk about reporting of studies, then I would say that instead it's always needed, right?
Right. Okay. In this context, yes.
Thanks.
But I would say explanation is also at different abstraction level. If you are using a drug, all the physicians know that according to the drug you have possible consequences. But the mechanism at the metabolic level or different molecular level is not always the point you want to reach for understanding what is the final effect. That's the different layer you have to consider in the explainability.
Other questions? There is another.
Thank you. Can you hear me? Yes. I am a doctor and I have a question about research, because we are used to think about levels of evidence-based medicine now. So how can we trust research based on AI? Are there levels of accountability? I don't know.
Right, that's in the direction I was mentioning before. Explainability should support the trust in a system, because if you want to obtain some kind of explanation of why the system reached some conclusion, you should be supported and you can trust in the system. But obviously, you need some kind of path to obtain this kind of trust. It could be in a first step in the certification process of these software tools, and then in the standard use. But that's exactly the direction of the explainability, because otherwise you are not trusting completely in a system. That's not correct.
There is the last questions.
Okay, I think it's working. A while ago you said that using this AI you could possibly produce an image of something that could possibly be used to help the patient. But talking about computer science, this would mean producing a rendering image, and it's not quite as simple as we were talking just a while ago with genetics. That kind of question is just a yes or no question for the computer, and it's quite easy. In this case, producing a rendered image, it would mean that you would have to upgrade all the computers in hospitals in the whole country. Is there any plan for this? Have you questioned this with the authorities or something, or is this still theoretical?
I didn't understand completely the question. Could you repeat?
The question is if there's a plan to upgrade the computers, so...
Right.
Okay. Because computers nowadays in hospitals could not do this in a matter of seconds, which would be needed for...
Okay, so you say that the hardware and software in a clinical setting are not supporting completely this kind of methods.
Yes. It wouldn't be able to do this in seconds or minutes. It would take...
Okay, that's a direction, I would say, that is orthogonal to the problem of explainability and so on. There are many different approaches in this direction. Obviously, in the clinical settings, computers have to be updated, upgraded, and so on. But one of the possible issues is related to how to manage such kind of big data you have to deal with for obtaining explanation or supporting decision-based. There are different approaches named federated learning, swarm learning, or similar stuff, where you, instead of collecting the data in a single site, you distribute the parameters of your learning methods to different data sets, and the system exchange the final conclusion and try to provide some conclusion that is based on data in different databases. But that's not really the main, I would say, explainability is not really related to a matter of computation efforts and so on. It's more related to the analysis of concept and data together. And as for the platform, it is quite independent, I would say. Obviously, you need the computational tools for supporting this kind of efforts.
Thank you. I think we move
this
on. Sorry, you can
Sorry.
keep discussing this in the coffee break.
Okay.
Thank you, Carlo, and we move on with the next speaker.
Thank you. Next speaker is Professor Panagiotis Papatreu. That is approaching. Panagiotis Papatreu is professor at the Department of Computer and System Sciences of Stockholm University. He is serving as action editor at the Data Mining and Knowledge Discovery Journal, and he is a board member of the Swedish Artificial Intelligence Society. Please.
Great, thanks. Hello, everyone. Thanks to the organizers for the kind invitation. I'm always happy to find an excuse to leave Sweden to some warmer place of 20 degrees compared to some minor snow that we had yesterday morning. My talk connects really nicely to the previous one. So I'm going to try to give you some perspective of explainable AI with some examples. So I'm a computer scientist and I'm working at the computer science department, and I'm mostly working on machine learning. And when collaborating with hospitals, and in Stockholm we're collaborating with two big hospitals, Karolinska University Hospital and also Danderyd Hospital, they are always super eager to provide us with healthcare data, of course following the ethical and privacy constraints, and we are compliant to that. But they're really happy to talk to us about all these massive amounts of data sources. And I would agree also with the first speaker that we really need to collect even more information. It's not enough to have healthcare data as in electronic health records, but we need genomic data as well. We need to map all the different data sources and different modalities together for each particular patient. And the thing is, data is becoming massive. It's becoming also complex when it comes to healthcare and medicine. And that can be seen as a big challenge. And of course, for us, machine learning people, we are great with that. But it's also an opportunity to move towards what is called data-driven decision-making, and also convince specialists and medical experts that that's a very nice and promising direction to go to. And when I think a little bit about the past, right, so when I was talking to my practitioner or physicist when I was a bit younger, I would just simply trust the practitioner or the physicist because, okay, there was not so much AI there, and I would trust the knowledge and the intuition and the insights of that person. And I would just go ahead with all the recommendations. So back in the past, we didn't have AI, we didn't have so much data collected, it was just knowledge, right, that each individual person had. We had also different types of equipment for the practitioners and the patients. We even had different types of medications, right? But now we're moving towards more data-driven decisions. Mainly, we are collecting massive amounts of data, of healthcare data, and we have data scientists, perhaps, data analysts behind us, sitting behind these massive amounts, working or analyzing them, pre-processing them, preparing them for building ML models. And then the practitioners on the other side, they are looking into those models, they are looking into these systems that are managing, massaging the data, and they try to make their decisions based on the recommendations of those systems. Of course, we have a little bit more advanced medications and drugs nowadays. Even those, some countries, so my home country, I work in Sweden, but I'm Greek, so if you're in Greece and you meet this very nice and friendly physician that I showed you earlier, and you have a little bit of cough, you're going to be bombarded with medication, maybe a couple of x-rays, and you're all set. If you're in Sweden, the healthcare system is much, much more different. You need to be close to dying to be given attention or be given a little bit of medication so that you can survive. And I'm not saying one system is better than the other. They're different perspectives, right? And I would go somewhere in the middle. And of course, compared to this old type of equipment that doctors and patients had, we are moving towards that direction. Of course, we're not still having robots doing the surgeries, but okay, we are moving towards there. And of course, behind all this, there is artificial intelligence. And of course, there are different AI techniques behind it, but I would say the core is machine learning. And apparently, or unfortunately, there's a disease of deep learning that is also going into AI in medicine. And I'm calling it disease because, you know, yeah, deep learning is great. We're using it in my group as well. But unfortunately, it's not explainable. And it's actually a matter of no more feature engineering. You just are playing with different layers. You're just trying to engineer a network that will eventually work and give you the correct prediction without even understanding why. So the whole process is, you might be already familiar with it, but okay, you get some training data, we feed it to some learning process, some algorithm, and you learn some function that then needs to interact with a user, and in this case is a medical practitioner. And the main question of a medical practitioner is, well, okay, thank you for the prediction. Why should I trust it? Should I trust it? How much will it cost me? Is it better than the treatment that I already have in mind? And so on and so forth. And so far, the explanation that typically people would get is that from a machine learning person like me, it would be, yeah, well, okay, there's this very nice pile of linear algebra, trusted it works. I've been working on it for so long, and I've been getting very high precision recall, F-scores, AUC. I can give you many different metrics that are really high, and they work. So would you trust me? Well, perhaps yes, perhaps not. Perhaps you would like more explanations. And following up on the car example, I would use a plane example now. Suppose you are flying on a plane, let's say an Airbus or a Boeing. I would avoid Boeing now based on the recent developments, but let's say Airbus. And you're informed suddenly that, well, okay, there's no pilot on the plane. It's just an AI, a robot flying it. Would you trust it? Would you be comfortable sitting on that plane? Well, if everything is normal, I would be okay. But if I encounter some problem on the plane, some engine failure, I would start feeling a little bit nervous, right? It's similar as being a patient, right? So if I have some headache or if I have some minor flu, I don't mind asking some AI to give me some recommendation because that's normal procedure. But if, let's say, not good, I'm diagnosed with cancer, should I ask AI for it? Maybe not. I would like to ask a doctor who is assisted by AI. That I would trust a little bit more. Similarly to a pilot who's assisted by an autopilot. And then, still that's not good enough. If you want the medical expert or the target user to trust the predictions, there's different types of explanations you can get, as Professor Combi mentioned earlier. So you can get, for example, highlights on an image, on different images like X-rays, brain images, or retina displays, or scans, on which part of the image is contributing mostly on the prediction. If you have an ECG, you might get an area that is highlighted explaining where the diagnosis for that ECG comes from. Or you can get plots like this, which are called SHAP plots or SHAP value plots, where you can get for each particular attribute of the electronic health record, how does it influence the prediction of the classifier and whether it influences it positively or negatively. And following up on anti-hoc and post-hoc explanations, I would also characterize them, I would expand them a little bit more. I would say we can have global explainability and local explainability, as well as model-specific and model-agnostic. So, and there is no ideal case in this picture, but there are different situations, right? So you can have, you would like, if you have an explainer that would be added on top of your model. You either would like to add it on any model, so it should be model agnostic, and you would either want it to explain the whole model, what is behind the model, how is the model taking decisions in general, that's model agnostic global explainability, or you would like to go focus on particular patients or particular cases, this is local explainability, and then it depends, do you want to make it, to have it for any model, or do you want to have it for a particular model? And one other thing that is, well, I'm not trying to attack deep learning, but I'm attacking it. One other thing is that deep learning, as I said, is not focusing anymore on feature engineering. My argument is that is a little bit against it. So we should go back to feature engineering. Not too much, but a little bit. Because we should try to start by creating interpretable features or interpretable representations before we feed them to the algorithm. And how do we do that? We should consult domain experts. We should ask medical practitioners, what are those features that they're looking for? We should take all this useful domain knowledge that this very wise guy in the first picture had and try to integrate it in our learning process. And we can do it even from the very beginning, from our feature engineering stage. So for example, one way to do it is while looking at different variables that are measured in the clinic, well, if instead of looking at the raw values and then feeding them to a deep learning classifier and let it figure it out, we could come up with what we call temporal abstractions. We can come up with some more meaningful representations of those variables. We can say that this variable, for example, creatinine, was normal over a time period, even though since the small fluctuations might not make any significant difference in the outcome. And then this was overlapping by different intervals of glucose levels, sometimes high, sometimes low, sometimes high. And this representation could add up, resulting in features that can be picked up by the classifier that are much more meaningful. And then, okay, this is one approach, or if we focus on the interpretable features at the model level. What about interacting with the expert? Well, back in the past, when I joined Stockholm University, that was 10 years ago, I was working a lot on time series analysis. That was my favorite topic. And I came up, or with my group, of course, a small group back then, with a very nice classifier. It would take a multivariate time series, example ECG, 12 channels. It was a black box, unfortunately, but at that point in time, I wasn't so interested in whether it's black box or not. I just wanted it to work well. And it would predict different types of, in this case, myocardial infarction or chance of cardiac arrest within some time period. And at that point, we started collaborating with a medical expert at Karolinska University Hospital. That's him. Actually, he's a very serious person. He doesn't take selfies when being on patients and sending them to us, but this is a press, actually, in the news. And then we gave him this very nice classifier that can make these predictions, and his reaction was, okay, so what? I don't care. That's an oracle. I don't understand what should I do, and I don't understand why you are actually, why it is coming up with this prediction. So with the first type of explainability that I just showed you earlier, by highlighting parts of the image, we can answer one question. We can answer why. So we can highlight the regions and some regions of the ECG and give the practitioner some motivation on why the classifier has decided so. But perhaps this is not enough. Then the next question we will get from the expert would be, okay, so what? Do you have any suggestions? Can I change this? Can you give me more information on what is it that I could change so that I could prevent this from happening? And this is where we move to the next small hobby that me and my group and several other people, I guess, have, which is called counterfactual explanations. So again, what is a counterfactual? So if you build a nice classification model on some very nice cohort that you might have, you give it an instance or a patient, and you ask the model, okay, can you give me the class of the patient? And the model could say cardiac arrest. Okay, a counterfactual would be then asking the model back the question, or the explainer the question, okay, what is it that I should change in the patient configuration at the moment so that you can change your decision? You can tell me that the patient will not suffer from a cardiac arrest, or you will prolong the time of cardiac arrest. And the suggestions you can take would be, okay, try this test, add this medication, remove this medication, and so on and so forth. And these are some typical examples of counterfactuals. You get a patient, you get some recommendations, or you can have an ECG, the blue one, I don't know if you can see it very well. The blue one is the original one that has some issue, and the counterfactual of it is the red one on top. So then the domain expert or the practitioner can actually highlight the regions where recommendations are made to change the curve. And of course, now you will be wondering, well, okay, what is the counterfactual suggesting? How can it change the curve? Of course, in this case, the suggestion means maybe what you need to change can be changed by adding some medication to the patient, not actually by electrocuting the patient while the ECG is progressing, because that will not it will fix the curve somehow, but it might not solve the problem. But the main issue here with counterfactuals, also as Carlo Combi mentioned, is not about counterfactuals, but about explainability. How do you evaluate it? How do you assess the quality of those counterfactuals? And there are many measures. Yeah. I can list even more, but those measures mostly focus on, okay, I want to make as few changes as possible. I want the counterfactual to be as close to the original. I might want it to be valid. I want it to be fair. Fair meaning I don't want to give different treatment based on sensitive attributes unless it has to do with genotype and so on and so forth in medicine, but I want to follow the same procedure, same treatment, irrespective of sensitive attributes. But the main question is, how actionable are the recommendations that these classifiers are making? So when we were not constraining at all these counterfactual generators, we were getting recommendations such as, so the explainer was trying to change the BMI of a patient. And the recommendation was not change the BMI or lose weight. The recommendation was make the patient taller. Well, if you read some Greek mythology, it can happen, but I'm not sure if it will solve any problem. Or we could get recommendations such as change the gender. Well, yes, but that's not the point. So we had to constrain those classifiers or those explainers to make suggestions that actually follow the data manifold, and they are realistic, they could happen, right? And there are some easy ways to do, easy fixes, but still we're not there yet. So one way is to use autoencoders, and now people will be wondering, okay, you've been claiming that deep learning is a bad thing, and you're using deep learning now, autoencoders are deep learning, to actually generate explanations. Well, yes. Still, if you constrain them quite well, they can work. So one way to do this is use autoencoders, learn some latent space representation, and then which can act as a mechanism to generate counterfactuals that are closer to the data manifold. Right? But still, okay, another example, and then I will tell you the challenges. There's a similar problem for counterfactuals, but for the task of forecasting. So far, I was implying that we were working on classification. So you are observing a patient and you want to come up with a class label, sick, not sick, cardiac arrest, no cardiac arrest. Now suppose you're in the ICU, you're monitoring a patient, you have 100 variables there being measured, vitals, and you have let's say a target variable that you're checking. I don't know, glucose level, heart rate, how often an arrhythmia is happening. And you want to forecast the progression of that target variable, and you want to, based on the forecast, you want to find timely interventions. So in this case, you're observing this variable there, you're making a forecast with some confidence interval, but then based on the medical knowledge, you know that this variable should be within this band. If it goes outside this band, you need to make an intervention. So if your forecast says so, and that forecast could be short-term forecast, for example, then you need to identify the correct interventions at the correct point in time. So what other variables should you change, or what other medication should you give in order to make sure that the forecast stays within the boundaries? Here, of course, as always, as also in the previous example, you trust the forecaster, and you should trust the forecaster. So you want the model to be as well-performing as possible. Otherwise, this is meaningless, right? All And then you can even add constraints. You can say that I would like the forecasting to go upwards or to have any possible trend. And if it violates that trend, you can take the interventions. So the challenges here are, how are you going to define those constraints? How are you going to do the timely interventions? When are you going to do the timely interventions? And more importantly, do those timely interventions make sense? You might get a recommendation that you need to add another drug, but maybe that drug will interact with something else that the patient has been given. And you're trusting, or you trust that the counterfactual explainer will learn it automatically from the data. It will not always happen. So you need to constrain it and add domain knowledge, because we have plenty of domain knowledge. We have plenty of wise people like the one in the first picture whom we can ask. And we have plenty of medical bibliography that we can use to add this. So the recommendation, which is pretty much what everybody's saying this morning and I guess yesterday, is that all these systems, even the counterfactual generators or the explainers, their main purpose is to work together with a medical practitioner. I would claim that we should have explanations also for the safety of the patient or for the trust of the patient himself or herself. But again, in the example of the car and the plane, yeah, I drive a car. I'm going on planes, but I don't fly planes myself. I don't care exactly how the plane works. I don't even care whether the plane, what mechanism or what procedure the plane is using to take off and land in bad situations. I just want to make sure that the person who is in charge of the plane has the perfect knowledge to do it and is well experienced. And I want to make sure that the autopilot is not going to make any mistake. That would then result in the plane crashing. Yep. So my take-home message is when we're doing explainable ML, and we are doing a lot of explainable ML in also my group, and I guess many people here are, we should have the humans or the domain experts in the loop. We should ask them for domain knowledge, and we should understand the domain that we're trying to explain. Otherwise, we're building black box classifiers, or we are even engineering features that are not explainable or useful anyway. And there are also, the last point, trade-offs. When we're doing explainability, we might start risking model performance. We don't want to do that. We could compromise it in the sake of explainability, but we shouldn't drop the model performance just to explain something, to explain it, because then we're not explaining anything. We're explaining something that is wrong. And of course, privacy, we should have in mind that some explanations might violate privacy constraints, and we should have that in mind when presenting the explanations. Thank you very much.
Thank you. Any question from the audience? I have a, okay, go.
So you advocate feature engineering, and I mean, as you mentioned, in the end, that can lead to a drop in performance. But if we engineer features, we only engineer what people already know. And maybe the algorithms identify things we don't know yet, and maybe that is also an interesting part to complement what we already know, which might lead to future features as well.
Yeah, I totally agree. So the point here is that, yes, we should engineer features in terms of adding knowledge or guiding the system, the ML model towards what it should be doing or what it should not be doing. But we should, of course, let it also be creative, right? Otherwise, we're just constraining it to the knowledge we have, and we will never learn anything new. Yeah, so we should balance this. I totally agree. Yeah.
There's another question.
Thank you so much for the excellent presentation. I have a technical question. When you do your explanation using autoencoders, you think it's better to simulate the space around the data manifold using the data you have used to train the model, or independent ones?
So when generating the space or the autoencoders, we use both. So I think it's good to use the existing training set that you have, but then of course you might be missing information or you might be having noise. So you should, and we do that, generate or augment the space in some way, either by perturbing the existing examples or even by imputing. So there is another way to add, there's another chance to add domain knowledge. So if you have extra domain knowledge that is not represented in your training set, you can actually impute it by adding data examples that follow that knowledge. Yeah.
So we have no more time. Thank you very much for
Thank you.
Great presentation.
Thank you. We see the topic is of interest, so please take advantage of the coffee break also for discussing with speakers later. And we invite the last speaker of the session, who is Professor Pietro Liò, who is a professor of computational biology with the Department of Computer Science and Technology at the University of Cambridge, and a member of the Cambridge Center for AI and Medicine, the European Laboratory for Learning and Intelligent Systems, and the Accademia Europea and Asia Pacific Artificial Intelligence Association. Pietro, the floor is yours.
Thank you very much. Thank you for the invitation, and I'm very, very impressed by the number of students. I suppose MPhil and doctorate students. I think that this is a good indicator of a very healthy university. So, first of all, the first explainability is that I should explain that being the third in a row, I dropped a lot of definition of explainability in order not to be boring. And I filled with many, many examples or things that I want to talk about. I'm in the same institution of Michaela, and actually we are co-supervising students, so I'm really also enjoying being here with giving talks with Michaela. Now, the plan is about my idea about deploying AI in medicine, and then I will say on the parts of methodology, and I will give some examples across different scales. First of all, I had a lot of interaction with clinicians, and there are great expectations. I got terms like magic, or holy water, or devil. So in some sense, there are fears, there are expectations, is not, I'm not sure what are in the different fields of medicine, what are the real feeling. But let's start with a guy in Venice. And if we start with Vivaldi, you may notice that in the four seasons, there are both parts that adagio and allegro, vivace. So adagio is something slow, and I'm taking that as a sort of slow integration in medicine, and vivace is quite quick or disruptive. Let's put disruptive versus something that is a smooth integration. And the first is a work in collaboration with the University of Venice, with a colleague, a brilliant colleague, Marco Nobile, and a statistician in Milano, Giulia Capitoli. And we didn't want to be disruptive with respect to the clinical practice, so the decision trees are at the core of the doctors. Sometimes there are biases because doctors may have been trained on some cohorts or some textbooks, or they now dealing with different ethnic groups and so on. So there may be some bias. And what we have devised, for instance, is to improve the decision trees with adding probabilities, which means that it gives a lot of possibility for adding counterfactuals or understanding where is the uncertainty and to estimate the uncertainty. And that is, we added also some other aspects, like, for instance, the fuzzy logic, because as a father, for instance, I sometimes, well, my wife knows more than me that, but having the daughter, my daughter that has 38, let's say 37.9 Celsius degrees of fever, should I give a tachypyrine, which in some sense is a paracetamol, or to wait when the fever is, temperature is 38. So there are some decisions that are really a bit more difficult, and the fuzzy is able to adapt that. So that we have done this kind of preliminary work, and we are, that is, in some sense, it follows up and improves the kind of mentality and what is the practice of clinicians and doctors. In my opinion, is not enough, this I would call adagio, but it's not enough because the data that we are producing is really huge. Sometimes the decisions are more complex. The first plot is about intensive care unit. You have to take quick decisions on the basis of something that is changing in time very quickly, and there are several indicators. You don't know how to classify the patients. The second, for instance, is about a Parkinson dataset, very famous, and how to integrate something that is the whole brain, like fMRI, with respect to the methylation, which is something that is about changing in the DNA. And we know that both are very important for the, for instance, neurodegenerative diseases. Or how to deal with patterns. That sometimes even you have a severe disease and not every day is the same, okay? And that makes difficult to establish really the severity level or the, to point to some trajectories. This is, in my opinion, is where also, and that is my message, is not only AI that is important. I think that we have a richness of statistical methods, statistical modeling, mathematical modeling, and the idea is to put them together at work. It's not only the AI, but this is the trend. So usually we need to build the pipelines that have different kind of data, and then you need to use weighting the data depending on the quality, but depending on what they contain for the decision that you have to take, and also to harmonize the people who have expertise, which is not easy sometimes, because the medicine is taught as a very specialized fields and so on. So that is a kind of bench side and a bedside that needs to be harmonized, needs to be narrow and so on. So that the idea is that the AI that we are deploying may have supervised and unsupervised aspect and so on, but what we need is to have explainable AI, but more important, data stewardship, statistical methods that can control each step. And that, in my opinion, is something that we should remember. Now, if we go back to the initial question about how quick we should deploy AI, well, in some fields we really need to be quick. For instance, there is a shortage of pathologists all across the world, and particularly in Europe, there is something that is we need really to assist pathologists in the decisions. And there are also other kind of problems. I just took yesterday some titles, for instance, the fact that doing a surgery, for instance, if I have to do a surgery, to choose between a small hospital where they don't do so many of those and a big hospital where they do many, I think that I will go for the big hospital and so on. And at the same time, there are a lot of iatrogenical disease, so disease that you take in the hospital and so on. So that is, in my opinion, is a very important aspect. Another important type of data that we need to deploy is about super resolution. this is a paper, for instance, where we showed how to use AI to get super resolution. And here you can have a lot of explainability, for instance, with a sharp, there is a lime, there is other aspect that perhaps I can talk about. It can be a coffee break question. Now, another thing that I want to say is that there has been quite a polarization in the sense that the patient talks to the doctor and asks some questions, and the doctor talks to the AI scientist. It could be somebody from engineering, from mathematics, from computer science, or whatever. Actually, this is true, but it's less true, and perhaps we can move to make even less true, because in my opinion there is a lot of motivation in students from engineering, bioengineering, for instance, computer science, to learn a lot about medicine, but particularly students in medicine who have approached in a very serious way the AI. For instance, I have been supervising, usually I'm supervising PhD students who have a background in computer science, mathematics, physics, or chemistry, but I had also, for instance, two persons. One is British. Emma, for instance, she did medicine, then 3 years PhD with me on AI, and she was coding in a fantastic way, and then she defended in February last year. In June, she started the clinics, and now she's a doctor with a lot of expertise that also. Julio is me supervising, is the 3rd year. Emma has finished. Julio is the 3rd year, and Julio is very famous in Italy, I notice, and is me and one colleague, a friend, Maria Grazia Spillantini. She's a neuroscientist, and we are supervising him, and he's super brilliant from a medical, but also from a computer science point of view. And I received mail at 6 o'clock in the morning saying, Pietro, I've been coding all the night. And that is usually starts in this way, the mail. So this is why I think that important universities like Padova, Milano, Bologna, but many others, may have people who are not white flies, but are very important. They have important motivation to do. Now, I heard from the previous speaker some concern about deep learning, and I accept those concerns. What I think is important in deep learning is that all our world is nonlinear, okay? And sometimes it's not easy to pick up how much nonlinear is. So if we want to do modeling, we don't know what kind of nonlinear equation to put. And this is even testable nonlinear models is not easy. And all our body, like for instance feedback between cell signaling, or feedback between even organs that are cross-talking and so on, everything is nonlinear. So this is why I take the responsibility of using something that is contrary to statistics, where statistics you try to use very few degrees of freedom. Instead, we use a huge number of degrees of freedom, you see in large language models and so on, that have also non-linearity. Because they are non-linear, they can extract the non-linearity from the data. In my opinion, this is the only reason I'm using deep learning, the non-linearity. I really like it. I have one PhD in genetics, in genomics from Pavia, and the other PhD is in nonlinear dynamics and complex systems. So non-linearity in some sense is something that I like. So the other aspect that I want to say is that not only we are nonlinear, but we are very networked and in a very process-oriented. And I don't want to, this is, if you are interested, is another coffee break question, but I don't want to make the thing here. But everything is very mechanistically related. So we should move from the paradigm of organ-centric towards process-centric, and that will give us a lot of possibility also of drawing comorbidity maps and risk and see ourselves somewhere in a pathway, in a sort of Google map of a disease, okay? So that is. The fact that everything is a network means that I'm interested in this area, and actually, thanks God, I finished teaching this course 2 weeks ago, so now I am quite free to go around and meet people. So geometric deep learning is about the fact that the input of a neural network is a network, okay? Can be a network also very heterogeneous. We can put many, many different things, molecules, cells, people, and so on. And we can embed all this information, this network, so it's not each single node, but is each node with the neighborhood, and we can make different kind of prediction. What is really important is we model how the nodes are cross-talking, okay? So we model the way that the information is diffusing and is passing. And this has many, many types of impact. For instance, there is a link with mathematics of partial differential equations and so on. This is, but there is no time. So this is something that I really love, and you can have a mathematical function that describes the crosstalks between the nodes, okay? So that is what I'm doing. This is also related to transformers, so the kind of chat GPT, LLM, and so on, they are sort of transformer-like, and the transformer are graph neural network-like. And now the new trend, very sexy, is about to see the fact that the message passing can be lifted to more general topological elements like surfaces and so on, and that is called topological deep learning. And there are manifolds and so on, but I will not. Let me go quickly through few examples at different scales, okay? And I will disappoint you because I will not give you too many details, but I had already 3 coffees, so I can spend more time talking later, okay? So molecules. Now, something that actually I published 10 days ago was a work together with AstraZeneca people, very, very clever, particularly Dino Oglic. And the fact that some drugs, some interaction, you know very little, but it's cheap, it's inexpensive. Some other interactions, some other drugs, it's much more expensive. So you can, in some sense, you have to make priorities, but there are different ways. There are robotic activities going on. So we look at 28 millions of this inexpensive, and what we have done is to use this graph-like, where atoms are passing by messages, to find out how we can leverage the sort of single dose, so inexpensive, not worked, is low fidelity are called, towards the high fidelity. And that is something that we have done, and this is very important in drugs analysis, drug repurposing, and so on. And again, it works finding the best crosstalk, the best messages that atoms can send each other, okay? And I think that you can find the paper and you can read if you are interested, but this is about going from low fidelity to high fidelity. So it's something that is helpful, okay? So that is called transfer learning. And I will. The other important thing is that it's not only drugs, but you can scale up to proteins or protein complexes. For instance, this is very important, for instance, from a pandemic point of view, because if we are able to generate the right antibody for an antigen very quickly, this is something, is an injection and so on that could be done to at least to buffer the most extreme reactions and to proceed with follow-up activity. So this is very interesting because it uses graphs to constrain but it uses, and this is very interesting, what is generative AI is bringing, is a completely counterintuitive idea of noise. It's the noise that is helping generating variability. And this is very interesting because we are using to see biodiversity, that is something that has been checked by evolution. So there are small steps and then they are checked, while in the lab we can make many mutations and we can derive many variants. And that is this kind of using graphs together with the generative approach is quite interesting and has been tested. We did also some testing in the lab and we found a lot of improvements. So we can generate better drugs. Wait a moment. Better drugs for a specific interaction. Then perhaps there are so many other changes that we haven't tested with docking programs, and this is very also, what other interaction that could be negative and so you cannot use. But from the point only of studying an interaction, we can generate something better because we can generate many mutations and optimize on those mutations. This is something, is a field that is progressing fastly, and it goes from small molecules to large molecules and to material science. So I would say that the next aspect would be the material science, and this will be also important for prosthesis and for other, but I stop here. Now, let me tell you a few things on cell and tissue, and I will show also some explainability from this. This is something that we did 2 years ago on using gastric epithelia, and this is because in the epithelia, but not only in the epithelia, also the liver and so on, is really, there are geometrical patterns, so that you can take the eosin, you can take from coloring the cell with hematocylin eosin, you can follow the nuclei, and then you can see if there are, for instance, inflammatory regions full of inflammation or cancer and so on, you see a disruption in the geometry of the pattern. This is something that we are doing also with a completely different techniques, because instead of a visible light, you can use, for instance, infrared or Raman, which are responding with vibration of a molecule. So it's about vibration and vibro-rotational pattern. And this is why we are doing this, because we don't need to stop in the lab, so we can have a microscope in the surgery theater, we can take the biopsy, we don't need to prepare the slide, we just make in the microscope, get into the eye and the statistics and tell us what it's about, and then the surgeon can continue the surgery. So that is something that we have already the microscope, and it's a fantastic collaboration with Polytechnic of Milano. We have actually a couple of European grants, and Andrea Ferrari and other. Okay, so that I can talk. The other thing that I'm extremely interested in is tissues and single cells. But to see them in a different way, what we can gain, because I am into networks, if I am looking at the information of the single cell of the tissue, all the tissue of the human body, with different modalities, transcriptomics, methylation, and I'm using all this information, what I can get. For instance, this is something that when you are looking, not at a single node versus another node, but you are looking at many nodes with respect to one, or many nodes to multiple, it's very similar when you go to the movie, no? Usually you don't go alone, and when you go there, you meet other people. So this kind of multi-to-multi is called hypergraphs, and that is what we have done. We have done an hypergraph factorization, and I have also a student that was able to make a very nice drawing, so we got also the cover last summer. And the idea, for instance, is that you have a lot of tissues, and you can infer about the condition, what could be the transcriptomics of a tissue in certain condition that you don't have, or to have, for instance, in the biopsy of the heart. How much? 0. Ah, okay, so, perfect. So this is what we have done, and we got a lot of interesting impact on the biology point of view. And just to finish with 1 minute, if I have, thank you. And so this is, if you go to a doctor, the doctor, you start, I had a doctor actually when I was younger that he didn't want to sell too many medicines. So when I was saying, I have some pain here, he was saying, me too, and the other, so just not to sell. But usually what a doctor does, in the mind, puts you in a sort of graph with, append you to part of a graph of other patients that he or she had in the past. So this is something that you can see as a graph neural network. And this is something that we did. And you can think that each patient has a sort of fingerprint of information, so that this information could be, there are some common disease, rare disease, so you need to take into account of the statistics. But then using this graph neural network, you can, for instance, make a lot of prediction about the length to stay in the hospital, mortality, and so on. And you can get also, for instance, for different patients having the electronic health record, what are the things that are putting them so close in the graph. And then you can do a lot of, for instance, explainability on the graph. So you can find concepts on the graphs that are groups of patients that are behaving similarly. Or you can find, for instance, relationship between these concepts. Or you can even, and that is very important, and is going to be the next step of explainability, which has a very sexy name, that is neurosymbolic. You can have the logic. This is something that I did with the University of Siena and also Torino, Gabriele Ciravegna, and now Pietro Barbiero Milano. And this is a way that from the explainability you get the logic. What are the features that are important and what is the logic relationship of the feature? And this, if you get the logic, you can transform the logic in decision tree. Okay? That is. And this is something that we did, and we put everything together. The only last message that I want to say is that till now I showed something that is data-driven, but actually you can put together equations and data. So for a lot of physiological aspect, you, instead of the data that you don't have, you have equations. This, for instance, is something on type 2 diabetes that I did a few years ago. Yes, sorry. So this is a way that you put this together, and you have equation and data, and that gives you the possibility of exploring in a testable way comorbidities and risk maps. Stop.
Thank you.
Thank you, Pietro. You already booked a number of coffees for questions later, so I think we close here the session. There's a message.
Just to give you the time, we may have 20 minutes from now, so we'll cover at 11:30, okay? Have a good coffee to all of you.